My name is Bruce Kusan. I'm the Clinical Education Manager for Christie Medical, and I'd like to welcome you to our second webinar on vascular access issues. We have a distinguished panel of presenters, and I'd like to begin the program by introducing our two speakers. But first, I want to let you know that throughout the presentations, all attendees' phones will be on mute. We will be recording the presentation for later viewing. At the end of the presentations, we will be taking questions which can be sent to us by typing your question into the chat section on your webinar screen as shown. To collect your contact hour, go to the website or listed, and that will allow you to print your continuing education credit. Thank you again for your participation in this exciting webinar. Our first presenter is Dr. Gregory Shears. Dr. Shears is a pediatric intensivist and anesthesiologist with a long-standing interest in reducing patient complications and improving our approach to vascular access. He did his pediatric residency at St. Louis Children's Hospital, his anesthesia residency, pediatric anesthesia fellowship, and Pediatric Critical Care Fellowship, all at Johns Hopkins. He worked at the Children's Hospital of Philadelphia for 5 years and was recruited to the Mayo Clinic in 2001 to head the ECMO service. There he is the physician liaison to the nurse-led PIC team, medical director of the ECMO service, and co-director of the congenital heart unit. He is on the editorial board for JAVA and serves on the AVA Board of Directors as treasurer, and recently chaired AVA's Strategic Planning Task Force. He is very active with product development to help reduce complications and has given hundreds of presentations locally, regionally, nationally, and internationally. Our second presenter today is Melissa Whitehead. Melissa holds her BSN degree along with many vascular access certifications. She has been a pediatric nurse for over 30 years and is currently the manager of the clinical resource team at Children's Medical Center Dallas. Melissa was integral in the development of the vascular access team at Children's Health. She is actively involved in various vascular access professional organizations. She has presented at these organizations and has participated in many roundtable discussions related to pediatric vascular access. She is a contributing author for best practice guidelines in the care and maintenance of pediatric central venous catheter for the Association of Vascular Access. And now I'd like to turn the program over to Dr. Shears.
Okay, let's see if we can move this forward. Okay, there we are. So, hi everyone, and thanks so much for joining us today for this webinar. This is an exciting time for me in particular because we're talking about a topic that I have found very important. Actually, this topic is one of those that really sunk the hook for me in terms of my interest for vascular access. And I'm going to explain what I mean by that in just a few minutes with a couple slides around that. So for my part of this, a necessary combination for best practice is an overall theme, and again, you'll see why that is shortly. So from a disclosure standpoint, I need to say that I'm a consultant for Christie Medical, maker of one of the near-infrared devices. Any non-reference slides are based on my experience and opinion, and I'm a complete believer in the use of near-infrared as an adjunct for peripheral vascular access. So I think any of us involved in vascular access realize that we have a lot of problems, a lot of opportunities to improve patient care. And one significant problem that really is a barrier for us getting to the next level is the fact that we fail to prospectively manage our patients' vascular access needs. This is a stumbling block that is kind of at the beginning of the process. It is an absolute necessity to get to where we need to go. If we are not going to do adequate pre-access assessments, all of the rest falls apart to some degree. So this is a must. I want to convince you as part of this process, if you are not engaged in some form of pre-access assessment, to do so. And I'm going to suggest some things over the course of this presentation to maybe help make that process easier, because part of the barrier has been there's not been a good way to do it, to be quite honest. So the result of not doing proper pre-access assessment results in poor planning. And our patients end up suffering. They suffer because we're providing multiple sticks, and multiple sticks means unnecessary pain and suffering. And as a consequence, it should be no surprise to anybody that, Press-Ganey scores and other assessments of patient satisfaction have been really poor. And one of the themes that rings true constantly is that there is big patient dissatisfaction related to IV access and phlebotomy. And these are things we can do something about. We have the technology, we have the knowledge. We have not been dedicated to apply it in a broad way. And again, this is part of the reason for this conversation. So as a consequence of not doing things optimally, we are creating more and more difficult vascular access patients. I would say, or at least what I am seeing, is at epidemic levels. And so we are just spinning. We are creating more and more problems, which leads to further problems and further access challenges. We've got to break this cycle. And another thing that we are not doing adequately is we are completely underutilizing vascular access teams. They are the backbone of this process. We need to not disassemble. We need to assemble. We need to support. We need to develop adequate value propositions so the C-suite people get this. Vascular access teams are central to good, modern patient care. And so it is critical that we look at strategies to use them, deploy them properly, have them used as consultants to help with this pre-access assessment and creating an appropriate plan for patient care. As we fail to deploy this pre-access assessment stuff, we are just adding to the overall healthcare costs and to complications. Again, we need to stop this. If we can just get a hold of this upfront component, we can help bring down costs and reduce complications through better and more efficient healthcare management. So I apologize for any puns that I throw out here. People that know me know I'm a bad punster. So if 2 wrongs don't make a right, what do 10 rights make? Well, they make vascular access best practice. I was trying to think thematically about a bunch of different things that I've been exposed to recently, and I came up with, or at least this concept sort of fell upon me based on predecessors who have used similar concepts in different ways, and I'll tell you what I mean by that. But interestingly, right 10 or 10 right makes a lot of sense, and I'm gonna go over a few details about that and how that fits into this overall scheme. If you want the entire vascular access episode to go well, you need these 10 components like a checklist. So, just like we have been chipping away at the whole CLABSI thing and using our checklist and using insertional best practice and other things to really improve care, and we've made some definite success here, we need to get our hands around the entire vascular access episode from pre-assessment to line removal. And interestingly, as I thought about this, there's 10 main components that make up this process. And if we're going to have an ideal process, we need to get all 10 right. I think we could build a program around this, get it right, get 10 right. We need to have the right line, the right patient, the right clinician, do it at the right time, put it in the right site, use the right technique for insertion, have the tip position right, have the right securement, the right maintenance, and lastly, the right duration and removing that line when we need to. Now, we absolutely cannot get 10 right without pre-access assessment. Again, this is a stumbling block for us. It is a critical first step to make the entire process of getting it right work. So, part of, as I thought a lot about this presentation to try to deliver something interesting and meaningful, and I was talking to Mike Brazunas, and Mike is going to be presenting up at AVA in New York City about a pre-access assessment and some other things, particularly related to increased use of midlines. And his company, has this promotional scheme of right patient, right time, right line. And I kind of like that. I like to be right. We all like to be right. We like to do the right things. And so I think, in the back of my mind, that's one of the things that sort of made sense to me. And then our friend Nancy Moreau, who doesn't love Nancy Moreau? She's such a great educator, and she's got this wonderful program on vessel health and preservation, and it's titled Right Line, Right Patient, Right Time, similar kind of theme. And then, I came across this article in the British Journal of Nursing, Right Line, Right Patient, Right Time. This was published back in 2013. So again, same kind of idea. People are thinking about the time, patient, and line. What I'm suggesting is we need to broaden it to all 10 components that are critical for a proper vascular access episode for our patients. And again, people that know me realize I love medical history. I love the origin of things. And as I was going back through some of the literature, I found this article, which was really quite a good article, Stepping Beyond the 5 Rights of Administering Drugs. And, this is a basic tenet of nursing. And I'm sure that subsequent individuals, as they were developing their right type of approach, probably either purposely or maybe just subliminally thought about the right drug, right time, right amount, in the right way, and the right patient as something that helped that they may have learned in the past, which makes perfect sense and applies in other situations in the future. Notice that this article was published back in 1962. I'm guessing that most of the people listening to this webinar weren't even born then, let alone practicing. So Thora Kron is a very interesting author as well. I think she must have thought that this is such a basic thing she didn't even need to reference it, because she has absolutely no references in her article, despite the fact she's a well-known author and has published several books in the nursing literature. So what do we need, again, for an ideal vascular access encounter? Well, we have to provide a pre-access assessment. We need to take the patient history, understand thoroughly what the intended therapy goals are, examine the patient, consider what are reasonable vascular access options. Then we need to educate and partner with our patient. They need to buy into this. They need to understand what is possible, what we have to offer. And then we, as a healthcare community and as vascular access specialists, need to get the vascular access best practice 10 right. If we do that, the patient with a high probability is going to have an uncomplicated course, and that is the kind of success that we want. Nobody believed that we could get down to zero with regard to CLABSI. We're doing it all the time, or we're really, really low. I know we can do this. I know that we can apply these 10. We can do our best with regard to best practice, get all 10 right, and significantly reduce our current level of complications and issues. And if we do that, everyone is satisfied. Clinicians are going to have a significant professional satisfaction, and more importantly, our patients are going to be satisfied. That is what we're about, and that's what we have to do. Okay, so how the heck are we going to do that? Well, people have thought a lot about the algorithmic side of things. So this is an algorithm that I pulled off the Stanford website, and I suspect that Nadine Nakazawa and others contributed to constructing this. And if you look at these algorithms, a very common thing begins with IV access, what is the duration, and then what sort of vascular integrity or ease of access do they have. And so, that I think ends up being a stumbling block for many people, because how the heck do you assess that? It's just kind of do we just approach it and just all have different definitions and just kind of go with what we think? Well, that's part of the dilemma we're in. We don't have a means of communicating this intellectually, and if we can't communicate intellectually about this, we can't drive research, and we can't standardize. Here's another access algorithm. Nancy, I talked to Nancy Moreau earlier in the week, and she was so kind to send a more recent version of hers. And I like this one a little bit more. It's a little bit more straightforward, and it speaks directly, as you can see by the swirling oval, of good vascular integrity versus poor, how it's important to make that distinction, and how that distinction impacts your decision-making. So it's critical. It's up front. There's other issues, obviously, that weigh into your decision-making, including the overall duration, what you're going to give, and the type of the osmolarity and whether it's a vesicant, all of those things, which we all know well. So all of those things drive the direction we take regarding our device choice. But at the beginning of this, again, we get back to how do we make an assessment of that vascular access integrity? How do we communicate that? Where do we draw those lines? And I'm going to address that in just a second. And so for a little history, from my own history, this is an article that got me excited about the academic side of vascular access. So I've been interested in vascular access and the challenges thereof ever since my pediatric residency back in the 80s. And I read this article by Amy Barton, not to be confused with our own Amy Bardin, who, of course, everybody knows as a wonderful person. This is Amy Barton. She's a very accomplished PhD nurse who's at the University of Colorado Health Science Center, who's a researcher, manager, etc. And this is an awesome article. I recommend anybody interested in vascular access to go back to read this. It's a quality improvement project which really had a significant impact and was the first thing that I found with regard to this access algorithm, and really got me excited about this concept almost 20 years ago. So here it is. This is the vascular access planning algorithm that they put out, and notice, very consistent with these others, that they talk about vascular integrity, good or poor, and how that leads into decision making. So they knew very well back then about these issues, and this was a building block for our current thought process. And they actually had several phases to this project, which was started out as kind of a CQI project. And as they implemented this algorithm, even back then, almost 20 years ago, as a result of this CQI project, they reported in their results the need for fewer IVs, less difficulty starting them, and less stress. I'm not sure how they quantified that. They also reported significantly less time required for central line placement, and remarkably, even back then when people weren't paying that much attention to this, patients had significantly shorter lengths of stays. So, that's gold. That's immediate healthcare savings there if we can bring down length of stays. So very important. They showed it way back then, almost 20 years ago, and we can do that now with better practice. So going forward, this is a very rich topic. There's so many things. I'm like a kid in a candy store. There's so many cool things to talk about, but I need to focus the conversation on peripheral vascular access assessment. And so these are my objectives, to outline the critical importance of pre-access assessment prior to IV placement, to discuss the use of near-infrared as a screening tool, and to present a method for communicating this pre-access assessment. I've got to pick up the pace a little bit. The slowness of this advancement is doing a little bit of slowing me up just a little bit. So what must we do to solve this problem? So I'm going to talk about only two of the must-dos. We need to better define the problem, and we need to provide a practical screening tool. There's many more things that I hope to address in another presentation sometime. So defining the problem. So there's no standard method of screening that we have, no standard means of quantifying the difficulty of access or the limited veins that are present. We need to take advantage of modern technology and practices, and above all, we need a scoring system to allow us to communicate our findings, to put something tangible in the medical record, and to encourage better research in this area. So I'm going to propose a practical screening tool. So what do you need for an ideal tool for peripheral vascular access assessment? It's got to be easy to apply, make clinical sense, use current technology, provide meaningful categorization, allow our current algorithms to be better refined, that this tool could be validated and relevant to modern practice, and promotes research and continued quality improvements. So if you think about it, as you're going up to assess somebody visually, you put on a tourniquet and have a look. It takes some period of time, but with your eyes, you can look pretty quickly. This video isn't playing very fast, unfortunately, but believe me, it was very fluid and quick, and it allowed, just as you would look at a patient with a tourniquet on, you could see the couple veins in this young, otherwise healthy individual's hands, but didn't really have any other access. So a couple good targets, but nothing else beyond that. So you can do that quickly. Now, this one is almost humorous. I'm not going to let you watch the whole thing because it's just painfully tedious. As I'm trying to palpate all the areas, it takes a long time. It's clumsy. It looks goofy. And it's really not an effective way to assess a patient, nor I couldn't remember from area to area where I found veins. So it's just impractical. Similarly, using ultrasound either in individual pointed areas, or throughout the arm. Here you see me trying to do a multi-point assessment using ultrasound as a pre-assessment tool. And if this were playing normally, again, it's humorous because I'm touching down, looking, touching down, looking, touching down, looking, and it's crazy. It's not practical. You can't really do it in a meaningful way. Yes, I use ultrasound every day with difficult vascular access for deeper veins, but as a screening tool, it just doesn't work. Here, again, I'm not going to really have time to play this out well. This arm practically was dipped in ultrasound gel. It is just shining from all of the goo. I mean, how impractical and messy that is. But that's the sort of thing you would need if you were really going to try to completely assess somebody's peripheral vascular access using ultrasound in a screening way. So now you take out your near-infrared device. It's as fast as you can see. I'm doing this quite slowly, actually, so you don't get motion sick as I'm moving it on the video screen. But as fast as you can wave the device, you get information about what are your vascular access options. It's awesome. I mean, it is made for this purpose, and I bet that we could deploy this in a meaningful way in order as an aid for pre-access assessment. So here's my suggestion. To build a screening tool that meets those criteria of easy to use and other things, probably we should build it not based on historic information, such as, the DIVA score, the Kenyan. I mean, there's value to that in the predictability, but patients vary from time to time with different circumstances. So we need to kind of assess them, all patients at a point in time, at that encounter. And so if we do it based on our means of assessment, where we have assessment through sight, assessment through palpation, assessment through near-infrared, the use of ultrasound, or no access at all. So patients will naturally fall out in terms of their vascular difficulty. So what I mean by that, so for example, a patient like a bodybuilder with no body fat would be a V category. You can easily locate all kinds of accessible veins by sight. And I'll build this out a little bit more. Or you may have somebody that maybe their veins aren't so easily easily seen, but through palpation you could find them. Thirdly, a patient, in terms of their difficulty level, might not be able to be visualized, might not be able to be palpated, but you get out near infrared and you can easily locate them. So this scheme allows you to categorize a patient's level of difficulty based on these three different screening methods. As I said, the visualization part, that's easy. We do that every day. The palpation part, applying that easily, not so easy. Near infrared, extremely easy. And then we get into level of difficulty, categorizing a patient as ultrasound only level of difficulty, or they don't fall into any of the first four categories and they lack adequate peripheral veins, and they'll end up being, IO or central access for their approach. One could add additional quantification and qualification to this screening tool, if you will. One could categorize the level of difficulty or the level of veins that a patient has as either A, greater than 10 optimal choices, B, 5 to 10 optimal choices, or C, 1 to 5 optimal choices. And then you could further qualify their clinical condition as being a patient with renal failure, exposed to chronic steroids, have sight limitations due to amputation, mastectomy, other things. Maybe historically they have a profoundly limited dwell time for other reasons, or a pediatric patient, which brings in their own implications, or a geriatric patient, again, because of their poor subcutaneous integrity, brings in other implications, and of course the qualifier of bilaterality or left or right sidedness. All of these together could be used as a means of describing a patient's level of difficulty, and so following our pre-access assessment, we could actually apply this tool to quantify these patients, to describe them. And under these qualified categories, you could have subqualifications, a level of renal failure, etc. In pediatrics, their weight or their age could be additional qualifiers. So here's an example of a patient who's a difficult access patient who by visualization has no veins, and by palpation really has no veins. And so as we move forward then and we use near-infrared, we can see some veins. Not a lot, but there are some veins that are potentially good areas of vascular access. So how do we describe this patient to our colleagues or in the medical record? So, and I'm using the abbreviations here. So with our pre-assessment, visualization, from a visualization standpoint, V, by sight, bilaterally, no veins. By palpation, or T, touch, bilaterally, no veins. With near-infrared, bilaterally, this patient is category B, 5 to 10 options per side for vascular access. So how ultimately we as a community decide, if we just then describe that patient as an NBB, since they, rather than saying 0 for the other ones, because that's our best category for them, or if we decide to say all 3 categories because it describes the entire process relating to peripheral vascular access, is up to the future to describe. But I throw this out there as a potential, practical, easy way for us to get our hands around describing these patients. And so again, I hope this slide goes forward. Not moving. Try again. Again, something happened there. Okay, always fun with technical issues. I was a holdout with converting from a slide deck to computers, and I had this really fancy slide deck thing that went into a seizure mode instead